Hey!
The lift wasn't working and he was in pain, so I tried to lift him on my own. Yes, it's bad. I'll need help.
Can I help you with that?
No, I'm good. Thanks.
Workplace injuries hurt the most at home.
There are soldiers in my family. I first joined the Legion to honor their service. Now I volunteer there to be of service myself. I know my membership helps Canadian veterans get the support they need. I've personally seen it help veterans get through some pretty dark times. Many have come out stronger than ever. For a lot of them, the Legion feels like home. It's nice to be part of that.
Hello, welcome to Out of the Fog. I'm Lynn Hammond. Tonight, we're talking about COVID-19, and our special guest is Chief Medical Officer of Health, Dr. Janice Fitzgerald. Join us after these messages.
You're watching Rogers TV, St. John's.
Hey everyone, it is Jason Piercy, host of Out of the Fog on Tuesday nights at 7:30. You're definitely going to want to watch because you never know what I'm going to get into. It's all about community. It's all about you. So watch Tuesday, 7:30.
Welcome back. Dr. Fitzgerald, thank you so much for being with us here today. We know how incredibly busy your schedule is. Of course, you've become a household name, household face for people throughout Newfoundland and Labrador as the Chief Medical Officer of Health throughout COVID-19. Perhaps you could share with us your career path. What brought you to this point and this position?
So I started about 20 years ago as a family doctor, and over the years I think really started to look at some of the bigger issues that affect people's health, and realized that after a few years of that I really felt that I needed to try to fix some of those bigger issues, and so became interested in public health. That's part of what public health does, and did a master's in public health started it probably about 6-7 years ago and finished it in 2016. And then in 2017, I started working at the Department of Health and Community Services, and so.
And I keep telling people this is not a pandemic job. The Chief Medical Officer of Health is a sustained, active position all the time. Perhaps you could help people understand the scope, the accountability, the responsibility, even in normal times of that position.
Yes, sure. So, the Chief Medical Officer of Health, so we have new public health legislation which outlines the duties of the Chief Medical Officer of Health, and it is a position within government. We're a public servant. It's not a political appointment in any way. There are specific requirements for the role, for the job, and generally, the Chief Medical Officer of Health is an impartial, independent voice and role within government and within the Department of Health at the moment. So our specific responsibilities really, I guess succinctly, is to monitor and look out for the health of the population in general. So we monitor diseases, not just infectious diseases like COVID-19, but also other diseases. We monitor health conditions within the population. We look at some of the broader, what we call social determinants of health, and how that can affect the population. And there are requirements in this new legislation now that we have to produce reports on a regular basis, and that we actually have to do a population health health assessment report at least every 5 years. So, so there are a fair number of roles, responsibilities that fall under the Chief Medical Officer of Health in the new public health legislation that we have.
And so, of course, you know, you have to be preoccupied by COVID-19, you know, for this past 10 months. And there are, you have counterparts in all the provinces and territories. You work closely with the federal government as well. What are those interactions like?
So generally speaking, we meet 2 to 3 times a week, depending on where we are, I guess, in the pandemic. Right now, we're meeting about 3 times a week. So it's a multi-jurisdictional call. Generally, you know, the CMOHs are from the other provinces and territories are there, as well as federally, you know, our Chief Public Health Officer of Canada. And then there are other representatives as well from the province who usually sit in on those calls. So it's a very robust discussion usually, and you know, we're talking about the latest things we need to be talking about, discussing how we're going to approach things as a country, and then how each jurisdiction are going to be approaching things, because sometimes it is a bit different depending on where you are and what the epidemiology is.
And it is a bit different, you know. I mean, you'd think conceptually, you know, you take the epidemiology and the science and the expert advice, and things would be applied consistently across the country. That's not the case. So what is different here? Why is it different here? I would think our geography is a significant part of that.
Yeah, so our geography certainly has played a role. You know, we have to look at the number of points of entry that we have into our province, and, you know, compared to some other provinces, those are quite low. So, yeah, we are at an advantage in that regard. Certainly, but if we look at, you know, what's happening elsewhere in the country, this is a huge country, right? And what happens here is rarely what happens, you know, in the center of the country or over on the west coast of the country. And so it's, if we look at what the epidemiology is in each of the provinces at this point, you know, you can see how in places that have higher disease rates, that they would have to think of things very differently than what we would at this point. And so it is having a consistent, so our goals are consistent, you know, across the country, in that we want to reduce the burden of this disease as much as possible. We want to maintain healthcare capacity, while at the same time reducing the other impacts of control of this disease as much as possible. So those goals are the same everywhere, but how you can accomplish that goal has to be contextualized really to where you are, right?
Well, I mean, we don't have the close quarters and apartment buildings of Toronto.
Right.
You know, here, you know, in Newfoundland and Labrador, majority of people live in single dwelling homes, for example. So that would be a part of that.
Yeah, so certainly, yeah, you know, population density has a big effect on how quickly something can spread. And so, yeah, we have to consider all of those things here. You know, there are some advantages to being in the situation that we are in at the east coast of Canada and an island and fairly remote areas in Labrador. So we do have. Thankfully, we are in a good position right now.
And of course, you know, a part of, you know, even historically in Newfoundland and Labrador, a large part of our economy includes rotational workers who go to other provinces to work.
Right.
You know, if it's not your, you know, own immediate family, you know, there's a close friend, everybody knows a rotational worker and the challenges that they're facing right now with COVID-19.
Right.
One of the things I know that you have to keep on top of is clarity of information. So I'm wondering if perhaps you could kind of clarify the issue around point of entry testing, because that seems to have gotten a bit of carry in the media, and there seems to be some lack of understanding of why that's not the right choice.
So with any kind of test that we do in medicine in general, you know, you have to be doing a test to answer a specific question. And so that's the first thing. So why are we doing the test? With point of entry testing, what we have to remember certain things, you know, about the test as well. So the biggest drawback is that there is up to a 30% false negative rate. So that means for every 10 negative tests you could have 3 people who are actually positive. And so if the reason you're doing the test when someone comes in is so that someone doesn't have to isolate, if that's what you're hoping to accomplish with that test, then 3 times out of 10 you could be wrong. And so you have people who are not isolating and who are walking around and potentially have COVID and potentially can spread it to somebody else.
So can I ask a question? Is that because the test is being taken too early? That it's that
there are
3 out
variable
of 10,
reasons.
you know,
Variable reasons.
Okay.
So there's the function of that is that sometimes it takes a while for symptoms or for the virus to build up in your system, and so if you do the test too early, you don't actually get a positive result. Sometimes it depends on where the disease is in the body. So if it's more down in the lungs as opposed to up in the nose and the back of the nose, then you may not get a good sample either. So the sample would have to come from lower down. Sometimes it has to do with the way in which the test is taken. It may not take the sample from exactly where it needs to come from. And then there's just factors with the test. Every test has a false negative rate,
Sure.
Not every test is perfect. So, well, there are no test is perfect, I should say. So there's going to be false negatives with every test that we do. We call these sensitivities and specificities. So we know that if the purpose of doing the test is to allow people not to have to isolate, we know 3 times out of 10 when we have a negative that we're going to be wrong.
Right.
So that person then is potentially walking around spreading COVID. Right. So and
affecting their own families.
And affecting their own families.
Right.
Other people outside their families, anyone they might be visiting without a mask on, all of those things. So there is that to consider. Part of the reason that we have done so well is because we have our isolation in place, and people who come here from elsewhere do have to isolate for 14 days, which 99% of the time that is going to be enough to prevent the spread of COVID-19. We recognize the hardship that this can have on people who are rotating, back and forth frequently, and so we've tried as best we can to balance that by reducing the time that people have to spend in isolation. Certainly doing a test at 7 days. The longer you're here, most people will become symptomatic if they've been exposed by about day 5, day 6.
Right.
So doing that at day 7 certainly reduces the risk. That false negative rate falls significantly to, we're in the 2-3% range, right, at 7 days. So we're really looking at a safer way to do things at that point.
And so what's the rules for them right now for rotational?
So for anyone coming in who's a Canadian rotational worker, of course, anyone coming from outside of Canada still has to abide by the rules federally.
Right.
So anyone who's coming from within Canada, at the moment, if they're not coming from a site that's an outbreak, that is a recognized outbreak, and we do have a list of those outbreak sites on our website, they are permitted to isolate with their family. So normally when you come here, if you isolate, you're supposed to be isolating away from everybody, right? So rotational workers are allowed to isolate with their families because that was causing a significant hardship when we heard that. For those first 7 days, they are a little more relaxed with what they can do in the sense of leaving their property, going for a walk, going for a drive, those sorts of things. Still not allowed to go into public places and things like that. After 7 days, they can get a test at 7 days, and if it's negative, then they're permitted to have a more relaxed, but they do have to wear a mask when they go anywhere. If they're interacting with anyone outside of their family bubble, they really should be wearing a mask. Their family members, adult family members, need to be wearing a mask if they're coming into contact with the rotational worker when they're outside as well.
So I mean, it's a real juggle. I mean, a real balance, kind of, balancing the disease itself versus the needs of people and.
It's been challenging. There's no doubt about that, and I know that it's been challenging for rotational workers as well. And and I really do believe that that they've been really good at following the rules, and I think that's why we're in the position that we're in at this stage of the game, because people have been doing what they need to do to keep their family members and their loved ones and their community safe.
And of course, we have vaccines now. You know, we're starting to get people immunized.
Yep.
So let's take a little break, and when we get back, we'll talk about who's being immunized, when, and what the next steps for that will be.
Okay.
And we'll be right back after these messages.
All right, girls.
Mom, you said it's played again.
Workplace injuries hurt the most at home.
It isn't the heavy trays that make the job difficult, or the fast pace you need to keep up. It's not working another double because someone called in sick. What makes the job tough is the moment you realize a customer has had enough, and you have to make that decision not to overserve. Refusing service isn't personal, it's the law. We know it's not easy, but we're counting on you to keep us all safe. Thank you, servers, for doing the tough job.
And we're back with Dr. Fitzgerald. So let's talk about the vaccine. We now have 2 types of vaccines being distributed here in the province. So maybe if you could tell us a little bit about, you know, what vaccines are going where, and who's receiving the vaccines first.
All right, so, you know, with any vaccine that comes onto the market, of course, it's gone through a rigorous process of evaluation by Health Canada and been approved here. So both the vaccines that are available on the market right now are safe and effective.
Yeah, so let's talk a little bit more about that. You know, I mean, there is sometimes that chatter on social media, you know, about worries about these vaccines, about how fast they've been approved.
Yeah.
But you have confidence in them.
Absolutely. You know, normally a process for a company, a pharmaceutical company, to develop a vaccine takes 5 years. But in this situation, because the international community recognized the need for a COVID-19 vaccine, you know, there was monetary support to make sure that that happened. And so because of that, the manufacturers could actually compress the process. So there are several steps. You know, there's a research and development, and then there's a testing, and then there's a manufacturing process that happens. And usually the manufacturing process doesn't start until the testing's been done and it's been approved and all that.
An international collaboration, which is not something that normally happens in pharmaceuticals.
You don't see this, right? And these companies had people working on just this and nothing else, right? Like, so this was the focus. So what they were able to do was to overlap those processes so that the research and development was happening, the testing happened as the manufacturing capabilities were being brought online. And so we saw that. And obviously these got pushed to the priority for the research, the testing, and then the approval process. So, you know, but there were no steps skipped. All the steps were there. They were just compressed and well, I don't know, but compressed, but, you know, overlapped, I guess. So we really want people to understand that this vaccine is safe and it has been deemed effective in the clinical trials that have been done up to this point. So, and we'll still be learning lots about these vaccines as time goes on. We'll be getting real world experience with them, and that's really important stuff for us to get. So right now there are 2 types of vaccines on the market for COVID-19, and that's what we call the BioNTech version, Pfizer BioNTech, and then there's the Moderna vaccine. So both of them are a new type of vaccine, what we call mRNA vaccines, and so they seem to be working quite well. Their effectiveness is above 90% for both of them, which is excellent for vaccines, and so they're going to be distributed. We'll be getting more of the Pfizer product in the first quarter of this year, and then the Moderna, you know, we'll be getting as time goes along, and more of it later on. So right now, Moderna has been targeted because it's the Pfizer has to be held at a really low temperature, minus 70 degrees. We need special freezers for that.
So really the city,
Yeah, well,
kind of the metro
island
area? Okay.
The island,
in other
yeah,
parts
because
of the
we do
island.
have,
Okay.
we have those freezers in depots across the island, what are
Okay,
our
excellent.
vaccine depots. So we have a very robust vaccine program here all along, and there are what we call depots across the island and in Labrador. But just because of the nature of how, the whole logistics of distribution of the vaccine, it was felt that Moderna was best to deliver to some of those remote and isolated communities that we see in Labrador.
Right, and that started yesterday?
And that started yesterday, yes. So,
Nunatsiavut area, coastal Labrador,
Yes.
other parts of Labrador.
Yeah,
Okay.
so any of these, what we would consider remote or isolated. So, that's generally the communities within Nunatsiavut government, and then as well as the Natwashish in the Innu
And Shishish,
Nation.
okay.
And so those are getting done first, and then there were some remote communities on the south coast of Labrador as well that got done.
So, why remote communities? Perhaps maybe even just start about how do you prioritize? I mean, obviously everybody has a case to be first, right? So, and so I would think that, that's a very complex process of deciding, first of all, the frontline healthcare workers who would be having interaction with COVID. I think everybody recognized they were going to go first. But, for the rest of the population, how do you prioritize? Like, how is that process?
So there are guidelines, I guess, for doing that, right? So, and it depends on the disease that you're dealing with. But first and foremost, your priority, especially, the reason we have to do priority groups, if we think about influenza, which we have 400,000 doses of influenza, there's no problem. Anybody can get it. We have enough. Come and get it,
Yes.
which you can still do, by the way.
Yes, I've had mine. So.
It's not too late.
Yeah.
So there's no concern with availability. So we can give that to whoever wants it, right? But in this respect, where we have such a limited supply of vaccine right now, these companies are making it for the whole world, right? So we have a limited supply for us. We have to make sure, first and foremost, that we're protecting the people who are most vulnerable to the severe effects of this disease, who are most likely to be hospitalized, who are most likely to end up in ICU, and who are most likely to die. So that's what we're looking at. So in addition to that, of course, obviously you would consider the people who would be most likely to pass the disease on to those people. So that's why we target people in long-term care facilities, personal care homes. Obviously, we've seen the devastation that this disease has wreaked in other areas of the country. I think all of us recognize that they have to be a priority group. And then the people who work in those facilities obviously are at risk for passing it on because, and we've seen from many other places that what happens in long-term care facilities reflects what's happening in the community, right? So we need to make sure that those workers are safe. And then, of course, the people who have, from the beginning, put themselves at the front line, who are being exposed in emergency departments, ICU, COVID units, those people have to be protected. And so that's why they get to the in that first priority group.
So these are medical decisions. These are not like these are.
No.
These are based
decisions.
on best case medical advice with research
evidence
that's available.
and certainly looking at the science of this virus and who is most affected. And certainly we know right now the biggest risk factor for that severe disease, hospitalization, and death is age.
Right.
And the older you are, the more likely you are to be severely affected by COVID-19. And so that's where our priorities go. But we also know that, there are other situations where there may be vulnerabilities.
Higher risk
And
factors.
higher risk, yeah. So, and some of those remote communities, isolated communities, that is, they have limited access to healthcare facilities. There may be difficulty with physical distancing, with isolation, because of just numbers of people in households. So all of those things play a factor for where we decide those first doses go.
Okay. So in our last few minutes, you did speak about, age as a factor, from as an outside person outside the healthcare community and watching what's happened across the country. It appears to me that the management of our long-term care facilities of the disease has been incredibly successful. You know, we did have, I think, one case. You know, maybe you could speak about that. Like, why did that happen here?
So I'm going to knock on wood.
I know, I wanted to.
But I think for us, we did learn very early. You know, we saw early on what could happen in long-term care facilities elsewhere in the country. And so we took some of the learnings that those jurisdictions had, and we applied them here. So, you know, very early on, we recognized, you know, that we needed to limit the number of people that were going into these homes to reduce the spread from community into the homes. We needed to protect the residents by having the staff take extra precautions. So we instituted masking for the whole shift, so staff had to wear a mask for the whole shift that they were there. We limited staff being able to move from one home to another home because that saw spread in homes that were having outbreaks elsewhere. So, you know, and I think that having that large cluster that we did early on, I think really made people realize here, you know, we're so used to being a bit insulated here, I think, you know, because of our geography, that I think people realized, oh gosh, it really can happen and it can come here. And so I think people took it very seriously, and, you know, we're very grateful for that. And I think we've learned a lot, though, in the meantime. And so we hope that, you know, we won't have to put those severe restrictions in like we did before if we start to see
the hard work
spread.
paid off, and we've learned. So did you have any, you know, last comments, you know, to kind of say to people, you know, keep your mask on? I know people are getting a little bit complacent. But
it is. I mean, it's certainly. We're, you know, we've climbed a hill, and we're hopefully at the very top and starting to go down now, and that'll help, you know, we'll get to that point. But we still have a ways to go. Even with the vaccine coming in, you know, the first few months, we're not going to see a whole lot. And the amount of vaccine we're getting is certainly not going to be enough to give us, you know, herd immunity that everybody talks about. So we do still have to stick with those public health measures, wearing our masks, visiting, watching your contacts, you know, don't have large gatherings, all of those things. We still really need to stick with all of that to make sure that we can keep this momentum going and that we can stay in this good place, you know, until we can get enough people vaccinated that we feel that we're safer.
Dr. Fitzgerald, thank you so much for being with us today.
You're very welcome. Thanks.
And we'll be right back after these messages.
Call the Rogers TV viewer response line, email us, or connect with us on social media.
Thank you to Dr. Janice Fitzgerald for joining us tonight to talk about COVID-19, how it's being managed here in Newfoundland and Labrador, the vaccination process, and special concerns that government has to deal with every day. Of course, we have to deal with COVID-19 too, and it's going to be around for a few months to come. For more information about COVID-19, please go to the Government of Newfoundland and Labrador website. Thank you. Join us next time on Out of the Fog.
Call the Rogers TV viewer response line,